Assalamu alaikum wa rahmatullahi wa barakatuh. Welcome everybody, and thank you very much for joining us for this symposium. At first, I would like to thank Amgen for sponsoring this meeting, and of course, we'll also thank Kunuz Ritaj for doing the logistics for us to conduct this meeting. And the thanks also goes to the faculty who are joining us today as speakers. This is basically, we are in the specialized, first I introduce myself, I'm Dr. Usam al-Bashir, a consultant cardiologist, specialized medical center hospital. And it's an idea that came to me and to Dr. Ali, our colleague and the head of the department, to organize an event about dyslipidemia being a very major problem in the Kingdom of Saudi Arabia. And the idea is to talk about the local experience and the epidemiology in Saudi Arabia. And of course, we cannot go without also talking about the guidelines and what governing us to treat dyslipidemia. So we have Dr. Zuhair Awan. He's going to be the first speaker. And then Dr. Baha Suruji will speak after him. We have Dr. Awaid al-Shammari. He's going to talk to us later on about the PCSK9 inhibitor and their place in the today's management of dyslipidemia. And then I will talk about common mistakes in treating dyslipidemia in general practice. And without going any further, I introduce the first speaker, Dr. Zuhair Awan. He is a professor of the College of Medicine, consultant of lipid disease at the University Hospital, and he's a vice dean of the College of Pharmacology of King Abdulaziz University Hospital in Jeddah. And he's going to talk to us about dyslipidemia, the Saudi picture. The floor is for you now, Dr. Zuhair.
Assalamu alaikum.
Alaikum salam.
Can you hear me?
I can hear you.
Right. Thank you very much for the kind invitation. I was given the task of talking about dyslipidemia in the Saudi picture. So without further ado, I would like to actually present some of the work we have actually published in a paper format that talks about the improvement of initiative in the LDL management in Saudi Arabia, call to action. And actually, it was a fun project that involved cardiologists, interventionist, clinical pharmacist, and me as a lipid specialist. And I invite you to download and read it because it's available in an open access. So what is the global burden of cardiovascular disease in the Middle East? Of course, the mortality for cardiovascular disease and atherosclerosis is the leading cause of death in the entire region, in adult and both genders. Among the 6 GCC countries, Saudi Arabia, unfortunately, is the highest death rate from cardiovascular disease. So I think all of you have seen this figure where the mortality from cardiovascular disease, it lies about 46%. Actually, it's more than traffic accident and non-communicable diseases and cancer combined together. So every 10 Saudi individuals, there are actually about 4 of them have cardiovascular event. Unfortunately, cardiovascular disease and cerebral vascular disease and peripheral artery disease are underreported in Saudi Arabia. In the International Classification of Disease, or the ICD, coding system is not compulsory. So you can understand now why we don't have very specific or synthesis, very accurate reports. And one of the also uh, the the very worrying also things that we have in our region, the lowest average age for the first MI, the mean of about 51 years in average, and the inter-heart studies. Of course, plus the risk factors, conventional risk factors, they're present enhancers such as impaired glucose tolerance tests and chronic kidney disease and chronic inflammatory disease that taps into the chronic known risk factors. Nevertheless, dyslipidemia is the most prevalent risk factor among them. Again, this is a very actually famous slide published by Professor Ahmad Hirsi that shows that dyslipidemia accounts for about 68% of all risk factors. So this exceeds obesity and abdominal obesity, hypertension, and diabetes and smoking in our risk factors. And the sad part is this study has actually came after a previous study which Professor Adnus has published in 2007 and found dyslipidemia again is the most prevalent risk factors in cardiovascular disease. So from 2007 until 2017, nothing has changed significantly. That denotes that we are not doing a very good job as physicians. In the same study, the ACE, African and Middle East Cardiovascular Epidemiological Study, 70% of the outpatient had dyslipidemia. Only 16 were receiving lipid-lowering medication. 13 were not achieving the LDL goals recommended by the guidelines. A more local study before that in 2013 conducted by the Ministry of Health and looked at actually 10,000 of the population in Saudi Arabia. And again, this is in 2013 before the more strict guidelines that have been published. And they found that 9% of those population that has been captured in the survey had dyslipidemia and 20% had borderline dyslipidemia. 60% of them were unaware of their diagnosis. 2% were treated but uncontrolled, and 4% were untreated at all. This table comes also from our paper. As you can see that between 2008 and 17, dyslipidemia prevalence has ranged between 30 and 32 in the Gulf study in the population of acute coronary syndrome. In the general population, again, with the old guidelines, it was about 9%. And in the stable outpatient and the African and Middle East is about 70%. So this is a big number of patients with dyslipidemia. So again, it shows you that there's a gap and disconnect between the clinical guidelines and the current status in Saudi Arabia in the region. One of the reasons why we have this gaps and disconnect is actually the unequal distribution of resources between urban and rural area. As you can see in the PURE study, where they have looked at 5,000 participants with prior coronary artery disease event and found about 15% remain on statin after 4 to 5 years. So this is very sad. Actually, it was a little bit better in the urban compared to the rural area. When also we looked at the inter-heart study, also the urban population exhibit more atherosclerotic cardiovascular disease risk factors, where cardiovascular disease outcome were worsened in the rural area. So this paradox actually denotes that early detection and treatment for risk factor in urban area there's a disconnect between those two areas. In the Diocese Middle East study that conducted in Jordan, Lebanon, Saudi Arabia, and Emirate, patients were followed up after statin therapy for 3 months, and looked at more than 2,000 patients enrolled with 52% established atherosclerotic cardiovascular disease. 82 were very high risk, so this is a very high risk population. 62% did not achieve LDL target. So this is a huge number, again, showing you the gap or disconnect between the LDL and our practice. This could be because patient poor awareness, as Al Omran et al. Has alluded in his study, that the recommended LDL target in patients with coronary heart disease and peripheral disease, patients were unaware between 40 and 36% respectively in terms of coronary heart disease and peripheral disease. Again, this is another table showing you between 2011 and 14. The LDL target achieved did not range between 14 and 38. So we have not exceeded the 40% in every case. So this is again another disconnect and gap in how we treat our patient. Another disconnect and gap, big gap actually, is in the diagnosis, treatment of familial hypercholesterolemia. This is again an autosomal codominant genetic disorder characterized by an LDL above the 95th percentile for age and sex. Actually, this disease is prevalent more than what we think. In a study that we have conducted in terms of FH registry, we looked at more than 20,000 patient follow-up in hospitals and found that the prevalence of familial hypercholesterolemia is 1 in 232 follow-up in the hospitals. So this is a big number of undiagnosed, untreated patients. Of course, familial hypercholesterolemia carries the risk of premature coronary disease. And of course, the earlier diagnosis, the earlier treatment, you can actually tap down the atherosclerosis cardiovascular disease in those patients. So primary prevention is the best when you early diagnose and early treat in those individuals. With the newer guidelines, especially the strict ones, the European, we found now the cutoff for the LDL is lower and lower. Now, the cutoff is less than 55 milligram or 1.4 millimole is recommended for secondary prevention of very high risk individuals and primary prevention of those with familial hypercholesterolemia. So you have to lower your patient if you know they have familial hypercholesterolemia below 55 milligrams or 1.4 millimole per liter. You have to lower even further, less than 40 milligrams and less than 1 millimole per liter if those patients have recurrent atherosclerotic cardiovascular event. So again, lower is in terms of LDL. So we have a big duty to perform as physicians and healthcare professionals. And actually the goal is set by the World Health Federation. The cholesterol roadmap is published, and we have to reduce atherosclerotic cardiovascular disease by about 25% by 2025. And now we are in almost 2021. So in order to achieve that, we have to be adherent to the international guidelines and emphasis more on lifestyle modification as well as intensive medication therapy, especially for genetic dyslipidemia, where we have to quickly escalate the dose and combined medication whenever we needed to do so to reach our LDL goal. So in order to be more effective, we have to follow at least a clinical management pathway that is being recommended by different society. Actually, we have one proposed in the paper I referred to, where you have to identify risk factors at the beginning. Then you have to look at signs of dyslipidemia and pay special attention to medical history and family history in terms of premature coronary disease and risk factors. Then you perform your LDL cholesterol level, and you do it even in high-risk individuals related to the index case. You can perform a non-fasting liver profile, and there's a lot of data supporting that. And if it's normal, you can repeat it in 4 to 12 weeks. If it's abnormal, you repeat it in the fasting state, and you determine the level of intervention. Then you risk stratify your patient and determine the cutoff, whether it's absolute or percentage reduction, and you determine your treatment strategy. So you categorize your patient either to primary or secondary, and determine if he requires non-pharmacological or pharmacological intervention. If you reach your goal and target, then you maintain your patient on the whatever intervention he's on, and you encourage adherence and use combination therapy whenever is needed. If the patient is uncontrolled, then you have to refer to a specialized center, whether to a specialized cardiologist or endocrinologist or a lipid center that has a multidisciplinary approach with an lipidologist involve a dietitian, a clinical pharmacist, nurse practitioner, and a geneticist to perform genetic testing. And this is actually becoming more the trend, especially in academic center. So the treatment options, of course, is number one, statins, and it's known to reduce MACE in both primary and secondary prevention. And huge meta-analysis that conducted with a 26 randomized clinical trial, they have found that with every 40 milligram reduction in LDL cholesterol, you achieve 10% decrease in mortality, 20% in cardiovascular disease, 23% in major coronary event, and 17% in reduction in stroke. Sorry for the haziness of the slide. However, if you treat with statin, there still remain a residual risk in patients who do not achieve the target because probably they are genetic dyslipidemia, because LDL cholesterol is not achieved in very high level of FH individual because of mutation in the LDL receptor, or you reach your target, however, there's continue to be residual risk from poor uncontrolled non-lipid related risk factors like diabetes mellitus or chronic kidney disease, or the patient simply is intolerant to statin. However, we have to be very careful. We have today a presentation in terms of statin intolerant. Before you label the patient statin intolerance, you have to perform different steps to confirm that the patient is not dehydrated, or the patient is not deconditioned, or vitamin D deficient, or hypothyroid before you deny him the benefit of statin and statin pleiotropic effect. The second line is etilmib. Etilmib is a cholesterol inhibitor from the GI tract. Again, is proven to be effective in the IMPROVE-IT trial that demonstrated that the combination showed significant reduction in LDL by 20% and significant reduction in MACE and a safety profile. Your third line is PCSK9 inhibitor or protein convertase substituting cysteine type 9. It's a proenzyme that actually found to be involved in the LDL recycling. So it allows the monoclonal antibody allows the LDL receptor to recycle more efficiently and therefore reduce the cholesterol in the blood. PCSK9 inhibitors have been approved by the FDA initially for the treatment of familial hypercholesterolemia without clinical diagnosis to reach target. Then it was approved for very high risk patient with atherosclerosis, cardiovascular disease, and intolerant to statin, and also approved for very high risk individuals with ASCVD on maximum tolerable statin alone or in combination with ezetimibe and failed to reach the LDL target. Of course, they are backed, the PCSK9 is backed by clinical trials with outcomes, both in the Fourier trial and the Odyssey, slightly different population. However, they have been proven to have a very favorable outcome after 2-3 years, and they drop the LDL cholesterol by additional 50 to 70% on top of statin and decrease the risk of coronary artery disease significantly. So let's pause a little bit and talk about the challenges that are facing us as a community. So as you know that Saudi Arabia has the expenditure growth in terms of expenses in healthcare. However, unique to Saudi Arabia, we have a fragmented healthcare system. In other words, we have patient going to Ministry of Health, patient going to higher education hospital attached to education institute. We have the private sector. they all have their different mandate, administration, and funding. And the absence of medical record system, unified medical record system, and standardized clinical pathway, uh, again, uh, present with gaps in the treatment because patients are sometimes going from one institute to another. So that today they're following with me, tomorrow they're following with Dr. Osama as a cardiologist. However, I don't see what is the latest management plan for that patient. Therefore, the patient can risk that he's not going to be on target very soon, or not adherent, and this is all not visible. So this creates a disjoint healthcare system that creates more gaps. So there is hope and vision 2000, the vision of the kingdom 2030, where we have the transformation for the nation. And their main, and their on that main initiative, there's a program in the establishment of National Center for Health Technology and Assessment. It's an independent entity that helps maximize the efficiency use of resources. So, in other words, streamlining services and creating a unified system with very specific health outcome that is measurable, and it has a KPI, and intensify the physicians and institute to whenever they are more adherent to a standard. Another thing that I want to bring also to your attention, that us as physicians, we are not very educated in terms of health economics. Of course, and now we are using the word value in healthcare, and the simple definition for it is the health outcome achieved per dollar. And actually, this is something that we discuss in the paper. Uh, the government is spending a lot on healthcare. Uh, in 2005, they spent about 27 billion. In 2019, it jumped to 46 billion. So this is not unique to the kingdom. It's happening everywhere. The population is increasing. The population is aging. And by convention, we spend about 85 to 90% of that in secondary preventions. And we spend only 5% in primary prevention. Of course, this is a problem because we as physicians think that we, with using technology in acute coronary cardiovascular, in terms of putting stents instead of thrombolytic agent, we think we're doing the best to the patient. But actually, we are not doing, except we are treating the complication rather than treating the root cause. So economic consideration has been systemically neglected from clinical practice guidelines, except recently when, recently in the guidelines, the ACC AH 2018 guidelines, where they have recently involved the cost effectiveness of analysis of conducting for PCSK9 inhibitor, which was included in that guideline. So now we talk about cost effectiveness of medication and primary prevention. So the cost of prevention and drugs is generally lower than the invasive procedures and hospitalization that result from complication of atherosclerosis. So we have to mind shift between treating the complication and actually going back to the root cause. Of course, it's going to be, people are going to say we cannot really prevent disease by simply dropping LDL, although all the data support this recommendation. So this is again from the paper where we actually have our healthcare expenditure, whether non-public or public domain. We have a role, we have different roles in different categories, effect to address dyslipidemia burden. So the medical society have to actually prioritize prevention of dyslipidemia by providing programs, awareness. Actually, we have to develop collaborative effort endorsed by medical society to partnership with tertiary centers like the cardiac centers, and to limit the further events in the most vulnerable population in high risk patient. The medical society also, they have to incentivize dedicated training for dyslipidemia So and believe it or not, there's a fellowship in clinical lipidology, and there's boards in clinical lipidology that a physician can have more training and become more effective. Introduce CME programs. Again, this is what we're doing right now. We have the CME program dedicated for dyslipidemia. And also we have to generate local data. So this is, I cannot emphasize enough, because without local data, we cannot have our actually local guidelines. As healthcare professionals, we have to recognize the importance of the LDL cholesterol in the genesis and progression of atherosclerosis. We have to go back to the medical education and actually see if there's any gaps in education, be it in lipid metabolism or actually in genetic dyslipidemia, and we have to address that. Identify patients with high LDL and perform adequate risk stratification in order to diagnose and treat. And most importantly, dismiss myth related to safety of lipid-lowering agent and danger related to achieving very low LDL cholesterol. So again, with this potent medication like PCSK9, we are achieving unprecedented levels of LDL, and it's perfectly safe as per the major clinical outcome. As healthcare system, we have to establish sufficient primary care clinic to take from the population that are actually going to specialized physicians. We have to have unified clinical electronic medical health care to avoid redundancy and continuity of care. We have to create specialized lipid clinic that have a multidisciplinary approach and keeping the patient in the center, where they are followed by different educators and nurse practitioners, clinical pharmacists, and lipidologists. And most importantly, we have to have and optimize a standard clinical pathway as the one I have showed you previously. Before I end my presentation, I want to also put food for thought in a few novel concepts. The concept of providing incentives determined by value-based system. So as a medical system, we're not gonna anymore allow and tolerate redundancy and efficient in treatment. And the payment have to be for performance. We have to also design quality rating system that rank specialized primary care and lipid centers in order how much they are adherent to guidelines and how much they have achievement. Also, we have to conduct post-marketing survey and cost effectiveness analysis to launch healthcare initiative aligned with the Vision 2030 of the Kingdom. And before I end, this is the summary of my presentation. Dyslipidemia remains the #1 risk factor in chronic and cardiovascular disease, despite effective line of therapy, statins, ezetimibe, and PCSK9 inhibitors. A gap between clinical practice guidelines and actual practice is aggravated by this jointed healthcare system and fragmented system, and we have to align all of those health in institute in one platforms in order to give the patient the best treatment. Effort is to implement clinical pathway supported by local data is paramount and essential in treating and combating dyslipidemia. Finally, the concept of value in healthcare should be adopted among us. With that, thank you very much for inviting me first of all, and for your attention. And I'll be happy to address any question today or through my email. And I actually invite you to read our last publication available in open access and through this QR code. Thank you very much.
Thank you very much, Dr. Zuhair, and I congratulate you for just finishing just in time, and very interesting talk. While I was just watching what you are presenting, I felt that we were lucky when we thought of doing this symposium to not follow the norm of just bringing clinicians to talk about guidelines and cases to bring somebody that who can give us a good idea about the local picture of dyslipidemia in Saudi Arabia. As you know, in our program, we left the question and answer till the end of the session. So for now, I thank you again. And we shift to the second speaker, Dr. Baha Suruji. Dr. Baha Suruji is a consultant cardiologist who joined us in a specialized medical center hospital recently. He is an interventional cardiologist and he is an assistant professor at Tabuk University. Dr. Baha is going to talk to us about statin, the evidence, side effects, intolerance, the fact and the myth. Welcome, Dr. Baha. You have 25 minutes from now. Thank you.
I would like to start by thanking the organizing committee for this invitation in this important topic. And I would like to thank Dr. Zuhair for his elegant talk, who showed us by evidence how big and important the issue of dyslipidemia in our society and how far are we from implementing guideline-directed therapy. So today I will talk about the evidence why we are using statins, and then I will summarize the guidelines as simple as I can to make sure at least we have a starting point in different class or different types of healthcare providers that to implement the guidelines. So I have no disclosures. So my objectives, as I said, I will talk about introduction, evidence behind the statins, and then indications, then how we're going to start the statins in clinical practice and side effects. So statins has been used in clinical practice for more than 30 years. The first statins was approved in 1987. It was Lovastatins. And statins is the cornerstone for dyslipidemia. And we have a large body of data, actually more than 30 randomized controlled trials. So in general, how does a statin works? It inhibits the enzyme HMG-CoA reductase, which is a rate-limiting steps in cholesterol synthesis. As a result, there will be increase in LDL receptors on the surface of the cell that will move the LDL from the circulation to inside the cell. Then the other mechanism, which is anti-inflammatory, which is a controversial. Actually, there is evidence that statins decrease inflammatory markers like high sensitivity C-reactive protein, but we still clinically, we don't have strong evidence to suggest it has clinical evidence of decreased inflammation. So benefit of statins. So the main benefit, which I'm going to talk about in the next few slides, is decrease the atherosclerosis events. Non-fatal MI, revascularization, ischemic stroke, and cardiovascular mortality. And then the other benefit is actually for stable plaque. Actually, it has been proven that statins stabilize and decrease plaque size. So regarding the benefit, I will spend some time talking about this meta-analysis, which has been published in Lancet, basically meta-analysis combining 26 randomized controlled trials and then involving more than 170,000 patients with the mean follow-up of 5 years. So sorry for this busy slide, but hopefully I will be able to simplify it. So if you can look below the red line, basically these are the trials comparing statins versus control. And we have almost 21 trials involving this meta-analysis. And you can see the first concept of does statin versus control really decrease the risk of events? To answer that, we have to look at the risk reduction. As you can see, it is behind. The risk reduction is low, is less than 1. With the confidence interval lines is actually does not cross. When you look over all the 21 trial, actually this diamond shape in the lower part of the slide, actually you see it is way beyond 1 with a statistically significant p-value. So when we are comparing statins to placebo, yes, it does decrease risk. And then the second question is, the second concept I'd like to talk about, lower is better. When you look at these 21 trials, so in the second column here, LDL reduction, the amount of LDL reduction by millimole per liter, we see in the lower trial, in the lowest part is 0.35 millimole reduction. You see the relative risk reduction is not significant. But when you go in the higher part of this, for S trial, for example, is 1.7. Actually, you see it is very significant risk reduction. So lower is better, and it has been shown it is safe. Then above the red line, this is 5 trials, basically comparing 2 different strategy, more versus less, or high intensity versus intermediate intensity. So as we give more potent statins, we have more risk reduction. Unfortunately, every now and then in the clinical practice, we have some physicians, for a reason or another, they don't believe in statins and lipid. So I would like to I encourage you to read this meta-analysis to know why you are doing what you are doing in clinical practice. So then what exactly the risk we're reducing? So first thing is, again, if you look at behind, under the red line, the risk of non-fatal MI or risk of cardiovascular death. So when we're comparing statin versus control, actually is decreasing the risk significantly with significant statistical p-value. And then we're talking about revascularization, the same thing. When we're talking about stroke, so for ischemic stroke, yes, it does decrease. Hemorrhagic or unknown stroke, there is no evidence statin will decrease that. And again, when we're reviewing the data for in this meta-analysis for more versus less, as we can see, it has statistical significant decreasing the event as we go with more potent statins. So this is for the first point. The second thing is decreasing atheroma size. So as interventional cardiologists, this is very interesting topics. So there is 3 main trials prove this concept. The first one is reversal. All of these trials are IVUS-based intravascular ultrasound. So basically putting ultrasound probe inside the coronary, measuring the atheroma size. And then the first one in the reversal trial, they gave a potent statin, atorvastatin 80 versus bravastatin. For a year and a half, they followed these kind of patient, and then they do a measurement again. Atorvastatin showed there is a decrease in the atheroma size with significant p-value. And then another trial came, which is a single arm steroid trial. Basically, they brought around 500 patients. They followed them for 24 months, and they gave them a potent statin, the high intensity statin, rosuvastatin 40. And then after a follow-up of 2 years, they measured by IVUS, the atheroma size, and there was decreased by mean of 5.6% in the atheroma size. Then recently, another trial, not recently, in New England, published in New England 2011, Saturn trial, which basically compared 2 potent statin, atorvastatin 80 versus rosuvastatin 40. It was a double-blinded trial involving 1,300 patients over 2 years. Actually, and the result was both of them, they stabilize and decrease atheroma size, and with equivalent safety. So then I will spend some time to simplify the guidelines, especially the American College of Cardiology 2018, with the main purpose of simplifying it to make it easier to implement. So the main thing, the patient with the group or the patient with the highest risk for atherosclerosis, they will drive the highest benefit from statin therapy. And according to the ACC guidelines 2018, there is 4 different groups. So the first group is the patient with the clinical atherosclerosis. They call it secondary atherosclerosis cardiovascular prevention. The second group with someone with severe hypercholesterolemia, that means LDL more than 190 or 4.9 millimole. The third group, patient with diabetes, and the fourth group with the primary prevention. So regarding the first group, the patient with the clinical atherosclerosis, cardiovascular disease, how are we going to define this patient? So basically they have atherosclerosis event or documented atherosclerosis, either coronary, in the coronary vascular, like acute coronary syndrome or stable angina, or they have revascularization anywhere in their body, secondary to atherosclerosis or documented stroke or TIA, or peripheral artery disease that even include aortic aneurysm. These patients with the clinical atherosclerosis, they're subdivided to very high risk or high risk. So the very high risk, the one who has multiple major events, or they have one major event plus multiple high risk conditions. So what are the major events? Major events, basically, if they have an acute coronary syndrome within 12 months, or MI regardless of the time, or if they have ischemic stroke or symptomatic peripheral artery disease. If they have one of these, if they have multiple of these, we're going to call them very high risk. If they have one of this and then multiple of the high risk conditions, basically high risk factors like diabetes, hypertension, CKD stage 3 or more, of they are smokers, and then we're going to call them high risk, a very high risk clinical atherosclerotic patient. So then what we're going to do with them. So this is, I'm going to talk about class 1 recommendation and class 2A, patient with clinical atherosclerosis that immediately indicate high intensity statins. If the patient cannot tolerate high intensity statins, then we're going to go to moderate intensity. Then if the patient is at very high risk for atherosclerosis and we are considering starting PCSK9, you need to add ezetimibe. This is class 1 by the ACC guidelines. And then patient also in very high risk, not on LDL, then you have to think about PCSK9, which I think will be covered in the next lecture. So what is our goal based on the ACC? Our goal is 50% reduction. And then this is the first thing. Second thing, we need to bring the LDL less than 70. And in the European Society, actually, they go for more tighter goal, more strict goals, 55 or 40 of LDL if the patient has 2 events while he is on maximum tolerated statin. So I'm not going to spend time here. Basically, this was summarized in the previous slide. So patient without clinical atherosclerosis, but he has a very high cholesterol or LDL, more than 190. First, you need to think about if the patient has a familiar hyperlipidemia, and to think about genetic testing if they have a very high level. But any patient with the LDL more than 190 and his age between 20 and 75, he has to receive the maximum tolerated statins. If he's not on goal, add ezetimibe. Our goal in this type of patient basically to achieve 50% reduction with LDL less than 100. Third group, which is common in our community, is diabetic patient. So the patient with diabetes and his age between 40 and 75, basically that will qualify him for at least moderate intensity statins. This is the first thing to keep in your mind. This is a class 1. Then this kind of diabetic patient, you have to assess their 10 years risk of first atherosclerosis. How we are going to assess their 10 years risk is by pooled cohort equation. And unfortunately, this is not being calculated or represented in the notes in different hospitals I've worked with. The calculated risk, the 10 years calculated risk. This is very easy to do. It takes less than 1 minute, basically just an online, just if you search for pooled cohort equation, you will find it and you can easily calculate the 10 years. So diabetic patient, we said at least moderate intensity statins, but if he has a high risk and multiple risk factors, then think about or implement a high intensity statins. And then thirdly, fourthly is the primary prevention. So patient without clinical atherosclerosis, without diabetes and LDL less than 190, what we are going to do basically in these patients, it's recommended to do to calculate their 10 years by pooled cohort equation, which has been validated. And then we'll do, this patient will be divided either to low risk, borderline risk, intermediate risk, or high risk if they have more than 20% risk of developing atherosclerosis event within the next 10 years. So patient with the high risk, you need to initiate statins with the goal of more than 50% reduction. But the problem with the intermediate risk or borderline risk, you need to look for other risk factors or risk enhancers in this kind of patient. Basically, you need to dig deep if they have a family history of premature atherosclerosis, if they have a metabolic syndrome, if it's a female, she has some problem during pregnancy like preeclampsia, or she has a premature menopause. All of this will increase the risk. If it's still you are or the patient is not convinced that statin is beneficial for them, you can do a CT scan for calcium score. If you find the calcium score between 1 and 99, basically, and the patient is above 55 years of age, basically you can start intermediate statins. If you find that the calcium score is very high, more than 100, actually initiating statin is indicated. So before you decided your patient, basically he needs statins, it's beneficial for him, and you categorize him one of the different groups we talk about. Before you start statins, actually this is a class 1, you need to discuss and review a few things with your patient. You need to discuss with him the net clinical benefit of statins, why statins is recommended for you. And then you discuss with him the potential side effect. And then you need to look at his medications. Is there any possibility for drug-drug interactions? And then you need to emphasize on compliance. And you need also to look at if the patient has predisposing factor for the risk factor, which I will talk about later. Baseline labs before you start the statins, you need liver profile and CK as a baseline. Okay, then what drugs that interact with the statins? Actually, some of these drugs are very common. So first I will spend some time talking about the cytochrome B450. So all of the statins are metabolized by this enzyme, cytochrome B450, except pravastatin. That's why pravastatin is the drug of choice for post-heart transplant. So there is different type of B450 cytochrome. The one will metabolize most of the statins, which is 3A4. That will metabolize atorvastatin and simvastatin. Rosuvastatin is by itself is metabolized by 2C9 system. So if the patient is receiving inhibitors of this enzyme, so the statins amount or statins level in his body will be high, and that will put him at higher risk of developing side effects. So these are the medication, which I will simplify it in the next slide, but just keep in your mind, gammaparazole, which is sometimes given for management of triglyceridemia, hypertriglyceridemia, is contraindicated to be given with any statins. Okay, so inhibitors what are the inhibitors of CB3A4? As we said, the 3A4, which are the main enzyme that will metabolize the atorvastatin and simvastatin. So cardiac medication, amiodarone and delta-azim and verapamil, one of the common medication that inhibitors, and antifungal antibiotic like erythromycin, clarithromycin. So inhibitors of 2CP, which is the main enzyme that will metabolize rosuvastatins, are colchicine, which now being used as a first line or second line in pericarditis, and fenofibrate. So you have to keep in mind when you are using rosuvastatin, there is no. The other thing, be aware of this combination of simvastatin and amlodipine. This is a very common mistake I have seen in the clinical practice. Amlodipine has been shown that it is double the level of simvastatin in the body. The maximum dose you can give of simvastatin if the patient is on amlodipine is 20 milligram. So maximum dose of simvastatin is 20 if the patient already in amlodipine. So you reviewed your the medication list the patient on. You decided this patient need high intensity statins. Basically, this was taken from the American College of Cardiology guideline, this table. Basically, high intensity statins, we're talking about atorva 40 or 80 and rosiva 20 or 40. And with these has been shown to decrease the statin level by 50%. Moderate intensity, basically, if the patient is indicated for moderate intensity, I prefer atorva or rosiva lower dose or simvastatins. And then the question is, should we, if the patient indicated for high intensity statins, should we give him atorva 80 or atorva 40? Or the same thing for rosiva. So reviewing the data, and actually I prefer, if you do your homework very well, you go through the medications the patient is taking and you decided that the patient is at higher risk, go with the high dose, especially if the patient has no predisposing risk for statin associated side effect. Then you started your patient on statins, when to repeat or to look for if the patient reached the target. In the American College or even in the European College of Cardiology, they recommend to repeat the level of LDL, but it has to be fasting in this time. Repeat it 4 to 12 weeks. To me, from my practice, actually, I see 4 weeks is a short time to look at the level and to look at to make adjustment. So usually I would recommend 2 months to 3 months. Okay, then you start the patient already on target. He started to have some of the side effects. So what are the side effects that has been documented with the statins? So in general, statins is usually well tolerated and safe medication. So now in the literature, they are shying away from the word intolerance because intolerance is a very rare entity. And why it's rare entity? Because most of the patients who develop the side effect after they re-challenge them with the lower dose or with the different statins, actually they tolerate it. So statin side effect is usually up to 10%. And usually it's reversible. The main side effect is the muscle-associated symptoms. And the other one, which is the liver injury, which is rare. And then I'll spend some time talking about new onset diabetes and then memory and cognitive with statins. So the muscle symptoms associated with the statins. So there is a different flavor of that, starting from the very mild, which is myalgias. And usually myalgia or muscle pain with statins, CK will be normal. It is a proximal myopathies, involving proximal large muscles, and it is bilateral. And usually it's reversible. So what are the predisposing factors? Usually the elderly patient, female, and patient who's taking inhibitors of the CB system, and patient who has comorbidities like hypothyroidism or renal or liver disease. Asian ancestries, Japanese and they found they have higher risk of developing myopathies. The second, which is more severe than myalgia, when you have CK, we have biochemical evidence that there is muscle injury. When you have myositis or myopathies and with a positive CK above the normal limit, which is fortunately is a rare entity. Rhabdomyolysis is very severe when you have a CK more than 10 times of upper normal limit and you have a renal injury. And then finally, when you have a statin-associated autoimmune myopathy, you suspect this when you stop the statin for 3 to 4 weeks and the symptoms of muscle pain is persistent and does not resolve. And you rule out all other causes of muscle pain or myopathy. And then there is antibodies. It will be positive in this type of complication, which HMG-C reactive, HMG-CR antibodies, which will be positive in this patient. This is a rare. There is a few case report about that, and this to be managed by a neuromuscular specialist, and sometimes they will benefit from chemotherapy. So liver injury, it's infrequent. Actually, there is 3 different types: mild elevation of transaminases or elevation more than 3 times of upper normal limits, or hepatic failure. So transaminases is common. Actually, it's uncommon, but it's been documented in RCTs and observational. Hepatic failure is rare, is very rare entity. Memory and cognition, actually it's unclear and there is no evidence behind it. The story of memory and cognition started after a few case reports, and FDA issued a warning in 2012, mentioning that there's some memory problem, memory loss with statin use. And then since 2012 until now, there is more than 3 large-scale RCTs actually did not show any memory or cognitive disorder. So, does statin cause new onset diabetes? This issue actually was started after Jupiter trial. When Jupiter trial was published, which Jupiter trial is rosuvastatin in a primary prevention patient, actually there was signals and evidence that new onset of diabetes in rosuvastatin arms. So the question, does statin cause diabetes or cause the new onset of diabetes? The answer for that is we are still unsure of that. But it is a small risk and significant increase in those patients who has a risk of developing diabetes. What are the risks found in the literature? Basically, obese patient has body mass index more than 30, or patient has glucose intolerance, his fasting glucose more than 100, or he has metabolic syndrome, or hemoglobin A1C more than 6. These kind of patients who have this risk, they will have risk of developing diabetes. This is analysis from Jupiter trial, which was published in Lancet. Basically, in the left graph, as you can see, the patient without risk factor for developing diabetes, the risk factor we just mentioned, starting rosuvastatin in this kind of patient carries 0 risk or no risk of developing diabetes. In the other hand, in the right side, patient with 1 or more risk factor of developing diabetes, when they are starting the rosuvastatins, they have increased risk of developing diabetes. So then the question, we know statin decrease the risk of event, and patient who has a high risk of events and statin is recommended, and at the same time he has risk factor of developing diabetes. Should we start the statins on them or not? At the same analysis of this Jupiter trial, basically they showed us that patient with risk of developing diabetes and statin is indicated, actually starting statins is much better than holding the statins. Why? Because it still decreases the risk of non-fatal MI, stroke, and revascularization. And this actually been mentioned in the guidelines. It's class 1 for the patient who has a risk factor of developing diabetes, and statin is recommended. Basically, it's recommended to start or to continue statin therapy, but you have to emphasize on the physical activity and to weight reduction for this kind of patient.
You have 5 minutes, Dr. Baha, 5 minutes.
Okay. So then side effect management. So you need to identify and diagnose the side effect. You need to check LFT and CK to document what type of side effect he has. And then you need to make sure there is no drug was introduced to increase the statin level in this patient. So this was published in the European Society of Cardiology, what to do with the patient who developed a side effect. So basically we have to stop the statins after you make sure there is no drug-drug interaction, there is no new medication that cause increase of statin levels. You give him a holiday from statins, 3 to 4 weeks. If his symptoms is secondary to statins, basically you expect within 3 to 4 weeks, his symptoms will resolve. If there is no resolution of symptoms, you have to think about he has another disease or other cause to cause this muscle symptoms. And then after 3 to 4 weeks, you have to restart the statins by using a different class and lower dose with a slow titration and frequent follow-up to check for side effect until you reach a maximum tolerated dose. And then you check the LDL. If the patient on the target, that's good. If he's not on the target, think of adding another medication like ezetimibe or PCSK9 inhibitors. So some fact and myth about statins. This is a very common, most of the physicians think statins has to be given at night. For some patients, actually, it's difficult to take medication at different times. They prefer to take it at once. So is it true that a statin has to be given at night only? This is true only for the short-acting statins, like simvastatin or pravastatins. But for the most commonly used statin, high-intensity statins, like atorvastatin and rosuvastatin, this is not correct. It can be given at any time of the day. The second thing, does a statin cause memory loss? Actually, from the large RCTs, it did not show any data, and this being studied extensively, and there is no evidence for that. And actually, lowering the statin is very safe. Lowering the LDL to very low level, it is very safe, as been shown from the PCSK9 trials. Does a statin increase risk of cancers? This is completely not true, and there is no evidence from the large RCTs. So take-home message, actually statins has a very large data and evidence, and it's proven to decrease mortality. Lower is better, as been shown from the meta-analysis. Be aware of drug-drug interaction because this is a common entity in the clinical practice. And finally, statin is safe and well tolerated. I would like to thank you, and I'm welcome for any questions.
Thank you very much, Dr. Baha, for the very nice, comprehensive talk. And for sure, you're going to make my talk later on very easy because I will skip some of my slides. As you know, we left the question and answer till the end of the session. So we will go for our next speaker, Dr. Waid al-Shammari. He is a consultant interventional cardiologist in Sulaiman al-Habib al-Rayyan. And he is going to talk to us about the PCSK9 inhibitors, their place in today's treatment, the Saudi experience.
Okay, thank you, Dr. Osama, and thanks to Dr. Ali Masoud who invited me for this meeting. I do have another commitment, by the way, right after the meeting. So if there is any important questions that need to be asked, so if you can ask me at the end of this. I'll try to be within my allocated time. So right now is 3:35. So I declare, this is the disclosure. I received honoraria from Amgen, Sanofi, and AstraZeneca, and those companies are the leading companies who are manufacturing the lipid-lowering agents. So I'll talk about PCSK9 inhibitor, which is a proprotein convertase subtilisin kixing type 9, and it's an inhibitor which is fully humanized monoclonal antibodies injected subcutaneously. It's a new and has a new opportunities for cardiovascular risk reductions, additional by adding additional LDL lowering when used in combination with statin plus minus ezetimibe. So statin is a gold standard and it has to be available for every patient treated for dyslipidemia. In Saudi right now, we have 3 ongoing studies, part of the GOLD trials, the Albini trial, and local data in my hospital assessing the PCSK9 response. At the end of my talk, hopefully I can have snapshots of few patients. I choose them, what type of patients and what are the struggles we have with the PCSK9. So we'll start with the LDL receptor. When there is LDL particles, join the hepatocyte by the LDL receptors. And this combination will undergo endocytosis inside the hepatocyte. And in hepatocyte, there is endosome, the destructions here, where the LDL particle lysomally is destructed and the LDL receptor recycled again. And this is done almost 200 times, leading to LDL reduction. However, there is a PCSK9 protein in the body that regulates LDL receptor expression, and these proteins combine with the LDL particle and LDL make it so hard for the LDL particle to separate from the receptors. Then it will distract and will lose LDL receptors, and this will lead to less LDL receptor available, so then there is no reduction of the LDL. So the impact of the PCSK9, it's, as I said, humanized monoclonal antibodies that combine with the PCSK9 protein that prevent it from joining the LDL particle to the LDL receptors. Therefore, they are easily separated in the endosome, then it will distract the LDL particle and recycle the LDL receptors. And this is done 200 times, leading to more LDL receptor available in the hepatocytes, then clearing the more LDL particles. There are 2 large trials, elarucumab and evolocumab are the 2 available in the market, PCSK9 inhibitor, and the Odyssey and for those trials are the leading trial for evidence for the PCSK9 use. Basically, the sample, as you see here, is 20,000 in each one of them, and more in the Fourier. And the Fourier, they have the stable atherosclerosis. Okay. So I would like to start from here. Whoever doesn't know about the PCSK9, I repeat that one. LDL particle combined to the LDL receptor, then they undergo endocytosis inside the hepatocyte. Then inside the endosome, it will be hydrolyzed and the more LDL receptor will be available. This is done about 200 times for each LDL receptor, clearing more LDL particles and reduction of the LDL. So what happened in reality, there is a protein called PCSK9. This protein combined with the LDL receptor and LDL particle. This complex will prevent them to separate from each other. Then the LDL receptor will be destroyed. So more destruction of the LDL receptor, leading to no more LDL reduction. So PCSK9 inhibitor, it combined to this PCSK9, and they prevent it from combining the LDL receptor and LDL particles. Then when it comes inside the hepatocyte, they are easily separated and the LDL receptor recycle again 200 times, leading to further reduction of LDL. PCSK9. There are 2 trials, Odyssey and Fourier, a huge trial, thousands and thousands of patients, and it showed both of them reduction of 60% of LDL, each one of them. And both of them reduced the cardiovascular event by 15%. both of them. So as we know, and clearly showed by Dr. Baha, a nice presentation about the statin and the result of how the LDL reduction leading to cardiovascular events, and this is clearly showed in secondary prevention and the primary prevention, though it's not very impressive, but with the secondary prevention, more reduction with the more reduction of events with the more reduction of LDL. So the greater benefits comes with the higher risk patients, and the lower LDL receptor, LDL cholesterol get greater benefit as well. So how low can we go? It has to be dealt with separately from one patient to another. So Dr. Baha presented the American guidelines. I'll present a little bit of the European guidelines, and the European guidelines probably is more recent one, and it's published 2019, and separated people to very high risk, or moderate risk, or low risk. The very high risk, any documented atherosclerotic cardiovascular disease, clinical or imaging. But in diabetes is no more the CAD equivalent disease. It depends. If it's diabetes with target organ damage and 3 risk factors, or diabetes type 1 more than 20 years, yes, they are very high risk. Otherwise, the diabetes by itself, it has to have more than 10 years or a single risk factor like hypertension or the dyslipidemia to be considered high risk. The rest of diabetic people are moderate risk. So the target for those patients, for very high risk patients, it should be less than 1.4 and reduction more than 50% of baseline. So this is class 1 indication. Another class 1 indication in high risk patients. The high risk patient like patient with diabetes type 2, more than 10 years, but no additional risk factor. So the LDL target is less than 1.8 and the reduction of more than 50%. There is a weaker evidence to be if the patient has bombarded by another events during 2 years while the LDL is to the target, so we go to lower target less than 1. In familial hyperlipidemia, they have to have a special consideration where the LDL is so high, 9 or 10. So it's very hard to say go down to 1.4. So those patients, though they are sometimes in very high risk group, they have to have a reduction more than 50%. This is class 2A indication. So we need to have the 50% reduction and did not specify at what to go lower. So their recommendation will focus on PCSK9 inhibitor, and they are indicated in very high risk patients, unable to achieve the LDL, target LDL using the statin plus minus ezetimibe. Class 1 indication for secondary prevention and class 1 indication for familial hyperlipidemia. But for primary prevention, it's class 2B. Like in diabetes patients more than 20 years. Statin intolerance as class 2B as well. In ACS patients, it's another class 1 indication for PCSK9 patients who are not achieving the LDL within the 4 to 6 weeks. Target LDL is less than 1.4. And also in ACS patients in hospital, it can be initiated if they are already on maximally tolerated statin and ezetimibe and did not achieve the LDL. So we can give the PCSK9 while the patient in hospital for ACS, class 2A. Special attention to peripheral vascular disease patients. It's a class 1 indication. Why is that? Because the vascular disease patients, they have aggressive disease that extend not only the coronaries elsewhere. So those patients probably generate the greater benefit from reduction of LDL. And this showed very nicely, elegantly in the Odyssey trial. This is subgroup analysis where they divided people, about 20,000 people. So 1 vascular bed or 2 vascular bed or 3 vascular beds. So the more beds available, the higher benefit we get from PCSK9. Here, the the absolute risk reduction in the one vascular bed like coronary disease is 1.4. But if there is polyvascular like perivascular disease, carotid artery disease, and coronary artery disease, the absolute risk reduction is 13. So 13% is a huge reduction that cannot be ignored. However, we have to take in consideration in those 20,000 patients, the number of participants who have 3 vascular beds are not more than 180 people, but the majority of patients is here. So we need to take this concept with this limitations, but this marked reduction of cardiovascular event cannot be ignored. So that's why I separated peripheral vascular disease in a separate slide to say alirocumab or evolocumab should be considered in those patients with polyvascular disease. Let me start with a few patients. So this is a 70-year-old lady, is known to have dyslipidemia and diabetes. She had PCI to RCA in 2015, and she got recurrent angina. She's supposed to be in Atherosclerosis 4 and her LDL 5.9. So I was not believing her, but she said, yeah, sometimes it takes, sometimes not. So encourage, and after 3 months follow-up, she was in Doesstatin at that time because she had some side effects from Atherosclerosis. And usually we give the 4 weeks holiday for the muscle to regenerate, because if there is myalgia, it is myocardial, it's mitochondrial dysfunction. So hopefully that by 4 weeks it will regenerate. So we give Doesstatin. Again, she's not very adherent because of the muscle aches, the LDL 3.19. August 17, at that time we advised her to take ezetimibe. So she should be in Doesstatin and ezetimibe, and the LDL 5.5. She was not taking it. Then I decided that time to give her PCSK9. And remember, this is the start time of the PCSK9 in our 2018, and still the LDL like that because she's not taking her medications. And April 2019, this is the best LDL I got in this patient. She was on Doesstatin 20, ezetimibe 10, and PCSK9 inhibitor. And the LDL was 1.09. I was very happy. Then again, in December, she's not using her medication. So I'm struggling with this lady every time with her statin therapy. So believe it or not, she had the RCA 2015. She had no event throughout these years. And in early 2020, we did cardiac cath because she has angina, and I found there is mild instance stenosis. We did the FFR, it was nothing. And again, she's admitted on November with the angina again, and one of my colleagues stented her LAD. Another case, a 64-year-old man is known to have CAD, PVD, and had PCI to LAD and RCA 2016. So this patient is high-risk patient. He had this atheroma, large atheroma, and in echo, it was mobile. And he underwent TVAR for this big atheroma. So that patient was in Rosuvastatin 20, the LDL reduced to 3.63. Then we added ezetimibe. Then later on, we did with ezetimibe and Rosuvastatin, LDL 2.18. Then we added PCSK9. It reduced by 36. So there is a marked reduction to with the use of the PCSK9 or statins, 84% reduction. It's amazing. Case number 3, 72-year-old lady is known to have CAD, had complicated PCI to a lady on March 2017 in a different hospital. And she could not tolerate statin. And given that complicated PCI, we don't want her to be in another complicated scenario. So we had a hard time to get her take the Doesstatin. She was on Rosuvastatin and ezetimibe. It was great. Then she stopped it because she could not tolerate Rosuvastatin. And we tried the Atorva, we tried pitavastatin, and we tried simvastatin. All of them got side effects. Then at the end of the day, we are giving her Doesstatin only 2.5 milligram every Monday and Thursday, and she's ongoing with that. she has no complaint. With the ezetimibe, the LDL reduced to and the PCSK9 reduced to 1.5. So it's not the target, but this is the best that we can get in this lady. And this is 45% reduction of LDL. But having said that, this is in a patient who are on the low dose statin, very low dose, or maybe no statin. Another case, 80-year-old lady is known to have CAD, had cardiac cath on February 2017, showing mid-LAD disease and FFR was 0.84. That patient left for medical therapy. Those kind of patients, as interventional cardiologists, we are very keen in following up those patients because we did not put a stent and we would like to have our decision was right. So we're keeping follow up with them to make sure that they are in good medical therapy, to be the same as what we see in the clinical trial, like Syntax 2 trial and the FAME trial. So April 2018, she was on Atherosclerosis 40 and ezetimibe 10 and LDL 2.5, and we wanted less than 1.4. So it's not enough. So we added PCSK9 and it was 0.51, and she got muscle aches, and we gave her rosuvastatin 2.5 bi-weekly and PCSK9. In general, if you ask me, why don't you kept the ezetimibe? So we could, but 80-year-old polypharmacy, and I don't think that I need it to further reduction of the LDL and save money as well. So if there is a concern of saving pills or money, probably adding ezetimibe in addition to the statin and PCSK9 not mandatory. Though guidelines stated clearly patients should be on statin, then ezetimibe, then PCSK9 in this incremental order. This case showed the reduction of PCSK with the PCSK9, the LDL by 80%. Another case, a 43-year-old man is known to have familial hyperlipidemia. I already discussed the CAD patients, secondary atherosclerotic cardiovascular disease, but this is pure familial hyperlipidemia. He could not tolerate statin therapy due to abnormal liver enzymes, and he has antiphospholipid syndrome. He was on ezetrol. Spite of ezetrol is LDL 5.63. So we added PCSK9. It's 1.56. Then we stopped the ezetimibe as the patient has a loin pain and the LDL 2.4. So as I mentioned before, the target LDL in a patient with familial dyslipidemia is 50% reduction. They did not, at least in the European guidelines, stated a number that we need to follow. So based on that, the patient achieved the target LDL by PCSK9 alone. Then we need to have the statin therapy, at least as an anti-inflammatory agent, to be available in the bloodstream in that patient. So I gave him Doesstatin 10 milligram once daily, but he sometimes take it, sometimes doesn't. So the LDL, the next one was 2.06, which is good. 72% reduction of LDL. So these cases showed you how much the LDL reduction with the use PCSK9 in our society is not what we see in the clinical trial, which is 50-60%. It's actually 70-80% reduction. So this case is a 48-year-old, I think this is the last, 48-year-old man known to have CAD and hypertension, had PCI to osteoproximal LAD. So this patient had a brother who died suddenly at the age of 55. So having said that, osteoproximal LAD, this is near the left main. So if there is a problem in that stent, probably will cause left main disease and sudden death in this patient. So we are very careful with such patients. In November 2014, he was in rosuvastatin 10, LDL 2.77. I don't know why he was in 10. Then I think it was 14 before his heart attack, or before his PCI. So in April 16, increased to 20, and the LDL 2.26. Then in March 17, then thereafter we know that he has CAD, so we need to achieve the target of 1.5, 1.4, I mean, unless less than 1.4. The rosuvastatin 20 with ezetimibe, it's only 1.54. So I advise him to do the PCSK9. He said, give me another chance because I'm not so far away from the target. However, I didn't see him until the next year. And at that time, he was 2.31. At that time, we changed the gear that we have to have the PCSK9 within the regimen. And he wasn't PCSK9, but we stopped ezetimibe for one reason or another. But usually I don't stop it. But we stopped it in this patient. It was rosuvastatin 20 and PCSK9 inhibitor, and the LDL reduced to 0.66. This 70% reduction of LDL. So my conclusion, PCSK9 inhibitor is very effective to reduce LDL by 50 to 80% from the baseline, with mild side effect or no side effect. It has a nanoneedle that comes in between the skin cells that it won't feel pain unless it's injected rapidly from the fridge to the skin. It has to be thawed outside for 30 minutes in order to be well tolerated. It should be considered in every patient who is not achieving the target LDL despite of maximum tolerated statin and ezetimibe therapy. So far, anecdotally, PCSK9 inhibitor is very effective and safe in Saudi Arabia. Thank you.
Yes. Actually, I don't think there is any difference. And then most of the medications used in our community is Saudi FDA approved. And if it's a Saudi FDA approved, it is safe. It's based on data. So there is no difference. Sometimes when you give one class of medication or one class of statins, you find a less effect. Yes, we have seen that, but we need to stress on the lifestyle. And then if we don't reach the goal, add isotrol or non-statins.
Yes, with you. Well, دائما احنا عندنا saying درهم وقاية خير من قنطار علاج. يعني we are all pro preventive medicine, so we want to prevent disease from happening rather than having to deal with the complication of the disease. So as you all know that dyslipidemia and particularly familial hypercholesterolemia is a silent disease. So we don't see any symptoms for the disease until we develop an MI or a coronary artery disease. So this is again too late. So we want to diagnose, we want to screen first of all, especially in genetic dyslipidemia relative, and then proactively stress on lifestyle medication. And then if needed, we start medication immediately in order to prevent all the complication of atherosclerosis. I hope, again, prevention is a lot cheaper than dealing with complication. Complication requires hospitalization, expensive gadgets like stents, balloon angiography, radiation, unnecessary if we all practice preventive medicine.
Yeah, so for patient with the liver disease, the main thing is you need to make sure he has a stable transaminases. If the patient is indicated for statin to reduce his risk and he has liver disease, it can be used safely, but you need to be sure that he has stable transaminases. He's not in the acute phase of liver damage. So there is some data, and even it's reflected in the American College of Cardiology and the European Society of Cardiology guidelines that it is safe to be used with the patient with the liver disease unless they are in the acute phase where still there is ongoing liver damage. So if it is a stable transaminases, yes, you can use it. You can use it to start with the lower dose. and then close monitor with the frequent LFTs to see if there is an increase in their stable transaminases. So if you allow me, Dr. Osama, so actually at the beginning there was thought this ubiquitin or Q enzyme 10 is beneficial to prevent against side effect of statins. But actually all the recent trials and the big trials show there is no evidence this coenzyme 10 will prevent. There is no benefit of coenzyme 10 to prevent side effect or to treat the side effect. And actually it's given class 3 to use it in the American College of Cardiology as there is no benefit of it. So it's class 3, not to be used anymore. Yes, if the patient, this is an excellent question. It is safe if the patient, he has a side effects, especially as Dr. Osama mentioned, if this side effect is significant. So mild elevation in the CK or mild elevation in transaminases, i.e. That means less than 3 times the normal limit, no need to stop it. But if the patient has a serious side effect, yes, you need to stop it for 4 weeks. You give him holiday and then restart it again with the lower dose, different class, and then you go from there. So is it safe for the 4 weeks? Yes. And we are giving statins to decrease the over time, over long time risk. We are not decreasing a day by day risk. We are decreasing risk over the years for the second event. So managing the side effect in the acute phase is more important than managing the risk over a long time, especially with the patient with a serious side effect. So the maximum dose we can give of simvastatin is 40. It used to be thinking that we can give 80, but 80 was associated with high risk of side effect. So now the maximum dose we can give is 40 milligram. But patient with hyperlipidemia, they also have high probability that they have hypertension. Amlodipine is one of the most common medication used in hypertension. So they found that amlodipine 10 milligram, it double the dose of the simvastatin. So if the patient is taking simvastatin 20 and he's in amlodipine 10, that means he's actually getting 40. So the maximum dose, to state it again, of simvastatin, if it is combined with amlodipine 10, the maximum dose is 20. Actually, I would like to thank you for stressing this point. This is a common mistake we see in the clinic. Patient was on statins, which was indicated to decrease his risk. After a while, after they recheck the lipid profile, LDL is on the target or lower than target, then the doctor advised to stop the statin or to decrease it. Please, please, healthcare providers, if the statins is indicated, patient now with the low LDL, don't stop it. Continue the same dose. If in doubt, refer for second opinion. But this is a common mistake. I've seen it in the clinic. I'm sure Dr. Osama have seen it and other cardiologists have seen it.
Yes, I would like to say a few words. Thank you very much for actually for this initiative. I think we have addressed a lot of points, and there's a lot of message that our participants and our attendee has heard and experienced. I think they have to now to do the job, that take this knowledge and disseminate it among their colleagues. We have a big battle to actually go through, reducing the LDL to target in preventing disease and saving lives. Thank you very much for inviting us and for this initiative.
I just would like to thank you. This is very informative. And yeah, actually, as you said, it was beyond my expectation. Thank you very much.